Okay, thank you. Now we start.
I have to share.
Today, in this meeting, we have very distinguished and well-known hepatologist, Professor Sarin and Professor Bajaj. It's an honor for me to chair these sessions. The first speaker, Professor Shiv Sarin, he obtained his MBBS degree with 7 gold medals in 1974, his MD and general medicine in 1978 from Rajasthan University. He then moved to the Department of Gastroenterology at Pent Hospital of University of Delhi in 1983. Then he became a professor at 1991. In the early days of his career, Professor Sarin earned a fellowship program from the Japanese Society for Promotion of Science and worked with Professor Kunio Okuda at Chiba in Japan just after me. Subsequently, he received the Fulbright Fellowship of NIH and worked with Professor Roberto Grossman at the University of Yale in the United States. He was the first to develop the portal hyperdynamics in mice and reported the schistomiasis model of portal hypertension. Dr. Sarin was also a pioneer in the field of ACLF, and he created a puzzle ACLF Research Consortium. Also, ARC achievements are the total 95 centers, total 10,800 enrolled cases, also conducted 102 video conferences, published more than 40 manuscripts, and presented more than 50 abstracts. I'm honored to be part of ARC since 2009. Professor Sarin has been instrumental in introducing reforms in medical education, including the national eligibility entrance test. Additionally, he led the government initiative to integrate muffled into the National Disease Control Program, making the first country in the world. He received many awards, such as Padma Bhushan, Shanti Swarup Bracknam Prize, Tuas International Prize, G Files Awards, Ombarkash Bashan Awards. He published many books and more than 1,000 articles. Sarin is the founding chief editor of Hepatology International. Currently, Dr. Sarin is a senior professor of hepatology and counselor of ILBS University and is serving as chairman of the steering committee of APASL. Yes, Professor Sarin, now we are going to listen to you.
Thank you for your very kind words and a dear friend and a very respected colleague, Professor Kadir, for inviting me and the Turkish colleagues and friends, and I can see many of my dear friends, including Dr. Unmet. Can you see my slides?
Yes. We can see your just your screen, sir. Yeah. Now we can. It's coming.
Right now?
Okay. Again.
Now it's better. Yeah.
Because I'm not used to Teams, so we are used to Zoom in a way. Yeah. But I would like to now start, and thanks HGV, the initiative by Dr. Kadir and the group. I bring greetings from ILBS. Today I'll share you something which is very new also, and some which you already know. I have nothing to disclose. I know Professor Bajaj is going to discuss on management and clinical parts, so I will just discuss on the terminology, something new on Kyoto consensus, prognostic scores, and pathogenesis. This is the current data from ARC. Today, of about 11,000 patients, alcohol is in 60% as an acute insult, followed by hepatitis B. The chronic liver disease, today 2/3 of the patients in Asia is due to alcohol. Of course, viral hepatitis comes number 2. This has changed over 30 years. So what is the difference between West and East, and which definition is, as of now, better in differentiating the disease from the course of cirrhosis, and provides an opportunity for non-transplant survival and management options? So we are comparing currently available definitions of West and East. So the East definition includes: A is an acute insult, ethanol, Hep B, viral hepatitis, autoimmune. The cirrhosis or chronic liver disease is the center, and liver failure is a result of the acute insult, which is more than 5 milligram of jaundice and INR more than 1.5 with ascites and HE. And a central theme is reversibility. This is ACLF. And the patient has presented as a hepatic insult, liver failure, but has underlying cirrhosis and CLD. The Western definition, which came about 5 years later, makes liver failure unnecessary. The liver failure was seen in this canonic study in 14%, kidney in 18 percent, and multi-organ failure was in about 3/4 of the patient. So most patients were in the ICU. This is a data from Journal Tribeca on EASL and follow-up of 622 patients. Now these patients only had ascites, grade 2 or 3. Now you see the natural course of ascites. Many of them had refractory ascites, SBP, HRS, bleed. Then they have a second decompensation. Then they have a third decompensation and they die. This is the natural history of the disease. However, many of them are labeled as ACLF. This is the natural history. Now, in natural history, if you get kidney injury, varicose bleed, HE, or you have a refractory ascites, you will not call it as ACLF. But patients of cirrhosis will die due to something, and is that the reason to define somebody as ACLF? All right. So these were cases of decompensated cirrhosis who developed sepsis, shock, bleed, AKI, HE, and failure. They are, in my mind at least, an independent, separate group. The chronic liver disease patients who get acute insult and present with one particular phenotype, jaundice and ascites. You can have similarly patients with compensated cirrhosis who get an acute insult, but their decompensation is in the form of jaundice and ascites. Bevino does not accept jaundice as part of decompensation, but Apostle and others, we believe this to be true. If the patient has bleed, coma, ascites, AKI, sepsis, or a combination, they are still decompensated, but not as ACLF according to us. So Apostle has only one phenotype where there is a hepatic insult, jaundice, and ascites. This is a homogeneous group. You can start trials on this. This is a bit late, and this is somewhere you have different type of presentations. Now I want to tell you, if you use the Cliff definition, combination of this and this, there are more than 27 phenotypes, and Nexed also may have more than 27 phenotypes. So when you start a trial, you will need a clear inclusion and exclusion. With this, the inclusion criteria is quite heterogeneous. Bevino 7 said further decompensation from decompensated, and this has also different connotations. Let me simplify and tell you where the confusion lies. In East, aposal arc, acute hepatic insult, jaundice, coagulopathy, and within 4 weeks ascites and or HE in a patient with CLD/cirrhosis with high mortality. In fact, this was the original definition where all the CLIF members were part. Subsequently, the definition slightly got modified using the criteria, time-dependent criteria in an ICU. And now you can have jaundice or any inciting event. It can be drug-induced injury, sepsis, pneumonia, anything. You need 2 or more extrahepatic organs to fail with high mortality in a patient who is decompensated or compensated, and it is related to SARS bacterial infection, alcohol injury, and jaundice is not necessary in them. So what I want to stress upon is, as of today, ARC gives you a clear phenotype, EASL-CLIF gives you heterogeneous phenotypes. It includes more people, no doubt, but they all are different spectra, different cohorts. But we can't live with 2 different definitions or maybe 3 different definitions, and we need to start attempts to harmonize. And for that reason, we worked 2023 and 24 and met in Kyoto and had a 165 people minds to put together to a Kyoto consensus. And this is the seminal diagrams which I am showing you. Now, an acute insult in a patient with chronic liver disease F3, F4, or a compensated cirrhosis or a decompensated cirrhosis will have different connotations. It will have decompensation. This could be further decompensation, which can recompensate. Once there is decompensation, there is liver failure, which is 5 or INR more than 1.5, no extrahepatic organ failure. Now, apostle, Japanese definition, the Chinese definition, all include this. They do not include extrahepatic organ failure. While ASLD and Mexicans, they require an organ failure, but they have liver failure at its core. While in the EASL and CLIF definition, you can have an acute decompensation, which includes everything else except jaundice. But if there is jaundice in these patients or no jaundice, they can be considered as ACLF, but 2 or more organ failures are required. The further Nexeld and others, they generally have very severe multiple phenotypes, and this is another group of sick patients. Now, can you do a non-transplant? One of the conditions I showed you, why should you define an entity? So that you can save the patient, not that everyone is to go for a transplant. So this group of patients, there is time for non-transplant options, but maybe for the EASL or for Nexeld, they would be late. The spectrum of liver injury and liver failure in a patient with cirrhosis, as I showed you, the precipitant can lead to 2 things. With jaundice, it is ACLF, but if the patient goes to decompensated cirrhosis, decompensation, it could be acute or it can be non-acute or stable decompensation. What I want to show you in this, once there is ACLF, in 6 months there can be recovery and reversal. But the patient starts drinking again, gets another insult. This is ACLF again. Such patients may need transplant may develop multi-organ failure or so. So ACLF and ACLF again is one of the bases for the new Kyoto consensus. Let me explain why such things occur, why people behave differently. So here is a patient who has, compared to the normal, slightly less liver reserve. Then he gets an insult, his liver reserve goes down, and he gets ACLF. Then he improves, the liver reserve slightly improves. Then he may actually get recompensation. In a cirrhosis, he gets better. Even the cirrhosis may regress. If he gets another insult, it is ACLF again. Further, liver parenchyma goes down. These are actually just symbolic. And the patient may get an acute decompensation or a non-acute decompensation. Why I'm showing you, the concept is the degree and nature of acute insult and the amount of liver reserve. So this is our proposal for a unified ACLF definition. In summer of this year, we gave up this concept in Journal of Hepatology as a point of view, which has now evolved slightly more. So ACLF type A or type B, very simple. Type A is liver centric. Type B is not liver centric. It can be liver, it can be otherwise also. In type A, you have liver, coagulation, cerebral, and the main driver is the ARC score. You can have Chinese or Mexican or Japanese definition. ASLD, thanks to Jus and the colleagues, Dean, they have included liver into the ASLD 2024 definition. However, these definitions also need extra hepatic organ failure to define ACLF. So, in my mind, the simplicity of type A and type B is type A necessarily has liver as the core. And this was the first step. The second step may be taken in the coming ASLD when we meet there. So let me summarize this part. Liver is core to the ACLF syndrome. Actually, the term is acute on chronic liver failure. If you don't have liver failure features like bilirubin and INR, maybe it is something else and not ACLF. So liver is core. Organ failure, in my mind, should not be part of definition. It might become a little late. But it is open to debate, and we will have new definitions of organ failure in times to come. I'm quite clear decompensated cirrhosis is independent. It should not be part of ACLF. It has a separate natural history. Prognostic scores, we have jaundice, coagulopathy, and encephalopathy, and lactate. This was ARC score in 2017, and creatinine as a bystander injury to the liver was included. So this is the first score which has liver failure. Lactate is not normally appreciated. It is only in ALF you appreciate, but in ACLF also appreciated. So here you would see a patient who comes to you, his score can be 5 to 15. Bilirubin is high, but he has no HE, but his INR is high, his lactate is high, create is normal. This is on day 0, a dynamic score. If score is 9, this guy can improve. But on day 4, you will see that he has now INR worsening, lactate worsening, and creatinine worsening. His score from grade 2 liver failure has gone to grade 3 with a score of 12. This guy is not going to make it. Why? Because a lot of data and this analysis shows somebody who has an ARC score of 9, 1 unit rise from 9 to 10, by day 4, mortality increases 4%. And by day 7, by 5%. But if somebody goes from here to 12, so anything above 10, 1 unit increase, 10 to 11 or 11 to 12, increases mortality by 20% or so. So remember, this very simple score can help you in your day-to-day bedside management of patient jaundice, coagulopathy, encephalopathy, lactate, and creatinine. Use ARC score. In my mind, as of now, this is the best score. Let's say ACLF score. The patient has a bilirubin of 2, but he has kidney failure, he has creatinine of 4. Then he has vasopressors and he has pneumonia, lungs are bad. So this guy is ACLF. His score is 3 and 3.6 and 3.9 without having any liver insult. So he is a cirrhosis who got pneumonia and kidney injury and is in shock. So in my mind, this can be ACLF, but this is cirrhosis with complication of infection. His score above 64 makes him eligible for transplant. But how will you transplant? NextCell, as of now, needs patients to be included as ACLF, and Dr. Bajaj can correct me, those who are on RRT or have grade 3 or 4 or are in shock or need mechanical ventilation. With this, we have limited choices non-transplant. We only have transplant choices. So in my mind, of the 3 scores, the NextCell, ACLF, and ARC, best dynamic score is ARC, which can help non-transplant options. I'll now cover you very briefly some new aspects on pathogenesis. So in a patient who has got ACLF, there is cell death, hepatocytes as well as endothelial and macrophages die. There is release of cytokines. The stellate cells which lie in the space of disc get activated. Endothelium is dysfunctional, so vessels don't relax. And there is further vasodilatory effect of high bilirubin and bile acids, and MAP decreases. Now, a patient of cirrhosis may already have portal pressure, HVPG of 15. Now he gets an acute insult. His pressure suddenly rises from 15 to 22, and this rise leads to sudden development of ascites, renal dysfunction, bleed, and HE. So ACLF requires pre-existent portal hypertension of a cirrhotic or chronic liver disease, which increases rapidly. And it is different from CLD because there is inflammation, endotoxemia, increased nitric oxide, massive cytokinemia, hyperbilirubinemia. The cardiac function is bad, hypotension, and there is decrease in SVR, intrahepatic resistance goes up, and there is a circulatory dysfunction. One of the major players are bilirubin and bile acids, and therefore there is a rapid rise in HVPG. So ascites of acute onset means there is cell death and a hyperinflammatory syndrome. The second aspect I want to tell you is the way albumin changes in ACLF. Now there is acute hepatic insult, cells have died, so less synthesis. And bilirubin binds more. I'll show you this. This albumin is dysfunctional from a mercapt albumin, the classical mercapt albumin, non-mercapt albumin, HNA1 and HNA2, they increase and they are very toxic, especially to neutrophils. Then the albumin has a capability of increasing innate immune response, hyper. And nitrosoalbumin causes vasodilation, platelet dysfunction. So this patient, if you give extra albumin, actually it converts bad into short time. So we should not pump albumin. Now here in a normal person, 1 molecule of human serum albumin binds to one bilirubin, 1 to 1. But in ACLF, one molecule of human serum albumin, this is albumin molecule, binds through 3 molecules of bilirubin. And this is hyperbilirubination. This albumin is now non-functional and is bad. So we need to be clear that this albumin needs to be not actually used. So there is a rationale for removing albumin, not merely replacing. Hyperoxidized albumin needs to be changed. Now the third part of my talk is the mechanism of injury pathogenesis. So let's say normal liver is 100%, ACLF very broadly crude, 80% liver, 20% have 30% die. Now there is an injury, alcohol, virus, drugs. Within a period of 7 days, what we call as golden window, and we have shown these patients can go down. But if you manage them, maybe there is a spontaneous recovery. In decompensated, they may go down, they may come up, but not to the same level. Now, day 0 to 7, the changes occur. And how do the injuries occur? So, this is the gut. From the gut, the leaky gut, the bacteria, the lipopolysaccharides, endotoxins, they come through portal vein into the liver. And there is already an acute insult, alcohol or virus. So, liver cells are dying, LPS is coming, it leads to activation of Kupffer cells, dendritic cells, and stellate cell, and the process of release and activation of cells occurs. So the inducer here, the sensors are these immune cells, the mediators are your cytokines, which, as I have shown here, TNF, IL-6, IL-1 beta, and many others, they go into the blood, and the response is systemic inflammatory response and subsequently CARS. So this vicious cycle continues and leads to organ failure. But it all starts with an injury into the liver. This is the basis. Now I'll tell you the major important cell, the monocyte. How does the monocyte has problems? Before that, this very interesting and important paper from Risha and others also supports and communicates this. But this is metabolic way of looking at things. They say there is increased sympathetic nervous system activity, hypothalamic pituitary axis, adrenal axis more, and glucagon secretion is more. More lipolysis, please pay attention to this. More lipolysis, more fatty acids, and finally they have not shown, but there is a increase in the several of the lipidome is changed and several lipid molecules change inside. And ATP synthesis finally decreases. This is a pump failure. There is increased amino acids which are released because of protein breakdown, but finally ATP synthesis is low. There is also an increased glucogenolysis. And finally, the whole mechanism is based on glycolysis. This is the when where you have more ATP synthesis. But glycolysis is not good for us. And I'll show you some of this in the future. Now you take a cell. Please pay attention. This is basic science. Take a cell and let's say monocyte. Then this is non-mitochondrial respiration and this is mitochondrial respiration. The basic oxygen consumption rate is the basal respiration. You block it, the ATP production is blocked, so you come to baseline. But then you can also measure by using some blockers to increase to the maximum capacity. This is what is known as the spare capacity of the cell, which on the basal, this is the reserve of the cell. What we want to measure in a cell is the oxygen consumption rate and how much is the capacity to reverse. Let's take a healthy control and an ACLF. Oxygen consumption rate and the potential. So this is the reserve capacity in a healthy person. This is normal. This is the reserve. In ACLF, this goes away. Then the extracellular acidification rate, that is glycolysis, glucose dependent, also is lower. The oxidative phosphorylation, mitochondria dependent, is also low. So the one which you have glycolysis or mitochondrial, both are gone down in a monocyte. Now, over a period of time, this patient develops SIRS and sepsis. Now, what happens to them? If there is no SIRS, still okay, not 500 but 200 or so. Once SIRS develops, almost. And sepsis develops, the monocyte has nothing. He has no reserve capacity. It is a dead cell in a very, very short period of time. Doesn't produce ATPs, respiration is low, basal respiration, glycolysis. So your monocyte in a very short time gone. Now, you take three types of plasma. Healthy plasma, which you can see here, healthy. Now you have a plasma of patient with ACLF and ACLF plus lipopolysaccharide. You can see that the moment you have the ACLF plasma and the infection, the oxygen capacity is almost negligible. So how do you restore it? You have a patient who has ACLF. Due to ACLF, DAMPs and PAMPs, your monocytes have gone. There is a bioenergy failure. There is an exhaustion of the cell, cannot do phagocytosis. How do I improve it? What you do is use MSC, mesenchymal stem cell therapy. Mesenchymal stem cell therapy transfers mitochondria, and I will show you hopefully that mitochondria are transferred from here, this mass, the number has doubled, and this mitochondrial mitochondrial mass can improve your innate cells and also improve liver regeneration. So this is to show you that patients who have got ACLF, you can predict death if the glycolysis is less than 42 and the maximal respiration is less than 37 picomole. This was published. I hope this tells us that this cell is now, there is failure, you cannot do more in this patient. And once you have a transfer in the limitation of time, I'll just jump. Here I'm showing you that the culture of monocytes with mesenchymal stem cells in 24 hours shows you that mitochondrial transfer has occurred, and this resuscitates energy metabolism. In my last one or two slides, I'll show you something very interesting on plasma exchange. I showed you monocyte function goes down. With plasma exchange, you remove DAMPs, PAMPs, and cytokines. Monocyte function can be restored. Further, endothelial dysfunction is there. These cells are not working. This can be restored. Von Willebrand factor, which is released from the endothelial cells, is very high. This is the one which causes the injury and portal hypertension to go up. This can be reduced. Cytokines can be reduced. So plasma exchange in a way can help in preventing organ failure, and if organ failure is there, may try to improve it. This is to show you I'm not covering the management. This is the proposed one slide management. So patient of ACLF comes, please see, you can have the etiology. It is autoimmune or it is hepatitis B. You specifically give tenofovir or steroids. Delay, stop the drug. Control and prevent sepsis. Nutrition, IV or oral. prevent organ failure. You can give PLEX, plasma exchange, as a bridge therapy. It is emerging and experiment. So if patient comes on day 0, you will assess the ARC score. If ARC score is about 10, he may straight go for transplant. Or a MELD is above 30, you can say, look, you will need transplant, get ready. While he is getting ready, on day 4, you might see improvement in his condition. Maybe 60% of these ACLF can be reversed. But on day 4, it becomes worse, and by day 7, it is increased emergency transplant. Extrahepatic organ failure from beginning, like easel, cliff, neck cell. You, in our opinion, may need PLEX or artificial liver support. You may stabilize. Some good surgical centers can take directly. Otherwise, emergency transplant. But if he is not improving, he goes to multi-organ failure or presents with multi-organ or ARC is above 13, then you need to convince people to be on supportive therapy. These are some of my thoughts on this. I will now just summarize. I have shown you the challenges in terminology, but with Kyoto and maybe ASLD initiatives, we may bridge some gap. I've shown you in my mind prognostic score ARC is simple, use 10 times a day. Every lactate you can dynamically correct. Acute portal hypertension you have to manage by beta blockers or preemptive tips. Albumin used with care, and energy failure. We don't have much, maybe some experiments with MSC. With this, I will like to thank you for your kind attention and happy to have some questions if time permits.
Thank you very much, Professor Sarin. It was scientific feast and wonderful talk. Thank you very much. If you have time and if you accept, the discussion will be held in after the second talk. Do you have time?
I will probably go off to sleep now.
Yeah. No,
okay,
please finish the questions. It must be like 10 o'clock, like 10:30
okay, now
in India.
we are opening the discussion for Professor Sarin's talk.
Otherwise, just
if there is a question, if there's a question, please write on the screen, then we can show it. Thank you very much, Dr. Sarin. Excellent talk, of course, as usual.
Thank you.
Is there any question?
I have so many questions, Dr. Sarin, but I'm not going to
enjoy.
I'm not going to bore you right now because in San Diego we'll have a lot of time to actually go over this. So, well,
okay.
It's very late, right, in India? What time is it?
It's late, and I thank you for the invitation.
It's 10
p.m.
Yeah, no any question, but one more. We enjoy this talk. Thank you, Professor Sarin, and I hope to see you in San Diego. Thank you.
Yes. Thank you.
Professor Sarin, thank you very much. You organized the Kyoto Consensus meeting, and I was there. I hope for the ACLF, we can have a consensus in the world for 3 research group like ARC and Canonic Study, and also North American Research Group. Thank you very much.
Thank you. Thank you for all the colleagues. Bye-bye.
Bye-bye.
Okay.
Yes, now I would like to introduce the second speaker, Professor Jasmohan Bajaj. He earned his MBBS from New University in India. He completed an internship in internal medicine at Delhi University and an internal medicine residency at the State University of New York Health Science Center in Brooklyn. He furthered his medical training with a fellowship in gastroenterology and hepatology at the Medical College of Wisconsin. Active in research, Dr. Bajaj has served as a principal investigator for numerous clinical trials in hepatic encephalopathy. Dr. Bajaj frequently presents his work on hepatic encephalopathy, microbiota, and chronic liver disease nationally and internationally at meetings, grand rounds, and symposia. He was a member of the ASLD Hepatic Encephalopathy Guidelines Writing Committee, headed the ACLF Guidelines Committee, and Dr. Bajaj is the chair of the North American Consortium for the Study of the End-Stage Liver Disease. He was the president of the International Society of Hepatic Encephalopathy. He was being elected to the American Society for Clinical Investigation and the Association of American Physicians. He's a fellow of ACG, ASLD, AGA, and the Royal College of Physicians in London. Dr. Bajaj is the co-editor-in-chief of the American Journal of Gastroenterology. He published many articles. Currently, Dr. Bajaj is Professor of Medicine, Division of Gastroenterology, Hepatology, and Nutrition at Virginia Commonwealth University and Richmond VA Medical Center. Yes, Professor Bajaj.
Thank you so much for this, and I'm going to share my screen. Please let me know if you see it. You see it?
Yes.
Okay, can you see the presentation mode or the other one?
Yes, yes, we can.
You see the presenter mode, or you see you see it's better now, right? You see the slideshow?
Yes, yes,
this is excellent.
better now.
Yeah, okay. Thank you so much for this introduction, and it is always daunting to follow my mentor, Dr. Sarin, and happy to always be, even if it's virtually, surrounded by my Turkish colleagues. So what is ACLF and how it affects critical care management? How do we define and prognosticate? I'm not going to spend too much time. Dr. Sarin did a great job with this. I'm going to focus on a patient that you'll actually see and what are the precipitants and potential prevention strategies, and a little more deep into what are the individual organ failures. Should they be given priority for liver transplant? Now, this is a problem in diseased liver transplant, but it's an even bigger problem in people who are undergoing living donor transplant. And what are the future directions, most of which Dr. Sarin has already covered. Like in everything, ACLF prevention is much, much better than cure. So I'm going to focus a lot before the patients actually become to the point where we actually have to differentiate them from decompensated cirrhosis to ACLF. So I'm going to talk about 3 guidelines. This is the first one, which is ACG, the American College of Gastroenterology. Then we have 2 others, the AASLD, as well as the EASL guidelines. What I have is a mishmash of all of these to try and, like was said, to get some common ground. So let's start with the presentation. A 59-year-old man is brought to his emergency room by his wife for new onset confusions and increased abdominal girth. Now, if you have a problem reading a lot of this, just focus only on the things that are in the red, okay? So there's uncontrolled diabetes, obesity, and social alcohol use. He's afebrile. He's oriented only to place, but he has a fluid wave in his belly. He has not sought outpatient care because he lost his job. And that's a problem in America. You know, if you don't have a job, you don't have insurance. But he had to undergo emergency surgery for a strangulated inguinal hernia 6 weeks ago somewhere else. Right now, serum creatinine is 1.3, bilirubin is 2, albumin is 3.1, INR is 1.4, WBC count is 7,000, and it is a low platelet count. There is no doubt in anyone's mind that this patient actually has decompensated cirrhosis and has hepatic encephalopathy with some kind of ascites. So now he has been in the emergency room for more than 8 hours, finally admitted. 14 hours, people finally do a diagnostic paracentesis showing that he has SBP. Now, we wasted 14 hours since the patient actually was confused. His IV ceftriaxone was started with albumin. Serum creatinine and WBC count have all increased, not surprisingly, since this patient has been ignored. Disoriented again 48 hours later, creatinine has now jumped to 3, sodium is low, bilirubin has jumped up as well, and so is the INR. The patient's repeat tap shows a lower reduction in PMNs, but unfortunately, he also requires IV norepinephrine. That time, terlipressin was not available in the US. Antibiotics are now escalated to meropenem and vancomycin, and ascites PMNs have not decreased by more than 25%. He's now tachypnic, hypoxic, with a new right-left lower lobe infiltrate in the lung. He is obtunded, anuric, all bad things happen, and ultimately, after discussion, the patient passes away without a liver transplant. And you can see it all started because people waited too long to diagnose with SBP, and once the SBP was diagnosed, it took too long for adequate treatment to happen. And therefore, this patient did not need to reach the ACLF status, but he did because of things that we could have done better as a clinical group. So obviously, when the liver fails, everything else fails as well. I'm not going to go into the specific things about the brain, lung, but literally every single organ you can think of is not doing well. There's coagulation deficits, there's respiratory, cardiorespiratory deficits, and there's inflammation, as pointed out by Dr. Salim. So definitions and diagnosis, I'm again not going to go over this, but here is the problem. We want to establish ACLF as a clinical entity, which is a homogeneous cohort of patients distinct from decompensated cirrhosis. We want to agree on a single prognostic index to stratify these patients for clinical trials. We want to determine definitions of organ failures on top of chronic disease and identify clinical trial endpoints. These goals are achievable, and robust evidence data would help all of this. Right now, a lot of what we're doing is based on feelings and what we've already put in the literature. What we really want to do is step back and be a little dispassionate and see what we can do over and above things that are too late. As Dr. Sarin pointed out, Naxalt may be too late, but it helps us in futility versus transplant. Some parts of EASL-CLIF and our criteria may be too early, especially for the liver failure part. So classifying everyone as ACLF does not help you. They should not get extra points on the transplant list. But those are things that are really important. And what we need to figure out is, do we need to have a specific biomarker that differentiates these things? We have the broad thing about acute decompensation. Then you have acute liver failure, which thankfully is not that common. And then you have patients with critical care without liver disease. And ACLF touches almost all of these things in one way or the other. What we need is a biomarker that is objective, reliable, specific, easily translatable, and determine who is a good candidate, which helps us determine who is a good candidate for liver transplant. So biomarkers that are currently being studied, some of which were mentioned by Dr. Sarin: inflammation, lactate, metabolomics, as well as microbiome. Let's go over with inflammation. It's not surprising that the more inflamed you are, the more likely you're going to have a bad outcome, given the central role of the liver in controlling inflammation. In this study from Padua, the more high-risk group had people with high CRP. Now, CRP is relatively easy to translate into clinical practice, but there is a lot of places where these things come from. You can see the AKI 90-day mortality, 28-day mortality in ACL development. There's a big overlap. So we struggle right now to figure out what is the adequate cutoff if we were to actually put CRP in there, or something much more expensive such as interleukin-6. There is clear-cut evidence, the higher this, the worse off you are. But for actual diagnostic and making people feel better, you really need to have a strong cutoff. The next thing was talked about was lactate. Lactate is in multiple organ failures, including some that we did. The Naxal group was part of this. As the number of organ failures went up, the MELD lactate score went up. So lactate did significantly add to the MELD score in the number of organ failures. In this beautiful study, again done to the VA, the MELD lactate was associated with this. And this study also showed lactate as a part of problem. So what is the problem with lactate, though? The big problem with lactate is, unless you're forced to do it as part of a clinical protocol, you only do it in people who are very, very sick. So there is a big selection bias that actually favors lactate. Because those people are much sicker, you will do the lactate on them. And those people end up dying a lot more because they were sicker to start with. So incorporating lactate is not an unreasonable thing, providing we do everyone gets lactate done in all times.
Merhaba.
What about microbiome? As we know, the gut microbiome is a critical part, and it's a very good organ. Excuse me, is someone speaking? Can you switch off your mute your? Okay. In patients who are gut microbiota, in this study, acute hepatic encephalopathy patients were very different in the microbiota from healthy, compensated, and decompensated patients. And this was able to predict who has a good outcome and who has a bad outcome. More scarily, the gut microbiota on admission was able to tell us who is going to live or who is going to die. So on admission, things such as Enterococcus, Pseudomonas, if it is higher in your gut microbiome, it does not matter what they do to you as an inpatient. You are destined to die. In this study, they took the gut microbiota of patients every day in the hospital. And this is the principal component analysis. Things that are closer to each other are actually related are similar. Things that are farther from each other are not related to each other. And you can see people who lived were in this blue triangles. People who died were in this red circles. You can see the red circles are clustered together. The blue triangles are not. Again, every day the microbiome can tell us who lives and who dies in these patient populations. Now it's been done in much deeper ways with patients with and without lactulose, but long story short, that the microbiota are a biomarker may be a little difficult to do in practice because the presence and absence of microbiota takes a long time to come back. It's also difficult to collect because not everyone is able to give you stool, and that might select out for people who are awake and alert and who are on lactulose, where the stool might be easy to collect. What about other things? Metabolites, microbial origin metabolites that can be easily detected in the circulating organs, such as serum or urine, can affect outcomes. In this study from NAXELD, we took 602 patients from hospitalized across many sites. We had their serum metabolomics, and some people had stool microbiota. We predicted outcomes controlling for clinical variables, did all these things, and found few metabolites. Aromatic amino acids, which are microbial origin, bile acids, and some xenobiotics. But more interestingly, estrogenic metabolites. As we know, as cirrhosis progresses, there's an increase in estrogenic metabolites because there's a lack of sulfation, and also the liver is not able to destroy this. So estrogens as well as microbial origin metabolites were independently able to predict not who has ACLF, but who is going to develop ACLF, which is the much harder thing for us to figure out. Then we go right here. We have patients in this European study in which they had patients who had already developed ACLF. And in that, you were similar metabolites were differentiating people who had ACLF versus those who had acute decompensation. So microbial products, not just the presence and absence of metabolites, could of the microbes, could be useful in diagnosing and predicting ACLF. And this will add some scientific nature to what we are doing, as opposed to saying this patient has already gotten organ failure. It's too late for most patients when we diagnose them when it's organ failure. We have to do it sooner so that we can improve our algorithm. And this is a study of all the metabolomic things that have been done in patients. In people with chronic liver disease, they can develop grade 3 and 4 hepatic encephalopathy called brain failure. Of course, acute and chronic liver failure, here we defined across multiple things, either CLIF or based on NAXELD. And the renal failure here was defined by requiring dialysis. Anything it's green were higher in people in whom this thing happened. Anything in red were lower in the serum in whom these things happened. So you can see phospholipids are pretty much lower in all people who have a lot of these things. But you talk about these individual things. Aromatic amino acids are higher in people who die or get ACLF. But look at the brain failure. It's very, very specific. Thyroxine is an isoleucine, which is a branch chain amino acids, is lower. And this was modified. We did this using actual clinical studies as well. Basically, this was a referral lab, but then we sent this labs to our local things because thyroxine can be detected. And we found the same thing. Low thyroxine on admission will tell you this patient is destined to develop grade 3 and 4 hepatic encephalopathy. Now, why would that be important? If someone is going to get so confused that they can't make their own decisions, you need to know that right now so that you can talk to them about what their wishes are, to see if they want a liver transplant, to see what's going to happen with them, and to prevent that as well. Now, again, ACLF, remember we talked about estrogenic sex steroids, but look at renal failure. Very unique set of metabolites that are not found anywhere else. Pyrimidine and purine metabolism and uremic toxins. So which tells you, which gives us a lot of heart, that metabolomics is not just the same thing. It's not just a reflection of liver disease gone bad, but every single organ failure has its unique stamp that we can potentially exploit to actually make this something better for our patients. So coming back to the management of ACLF, we talked about a little bit about biomarkers, how they're a little bit too late, and we need to make them better by potentially adding things such as inflammation markers, lactate, microbiome, or metabolomics. But here is what the individual organ failures are. Brain failure or acute hepatic encephalopathy is mostly hepatic encephalopathy. So you have drugs, you want to figure out that the patient doesn't die because of aspiration pneumonia. You want to evaluate for alternatives, identify precipitating factors and reverse them, and commence empirical therapy for HE. But the problem is there's a lot of other things that happen to our patients. They have hyperammonemia, They have alcohol intoxication. They could have alcohol withdrawal. They could have sepsis on top of that that causes encephalopathy. They could have the medications for sleep or pain that we either start in the hospital or unfortunately we stop because the patient is so confused and now they go into withdrawal. This can all lead to agitation, pain, and delirium on top of the hepatic encephalopathy that the patient was anyway going to get. So what do you do with these patients? If we start them on a long-standing fentanyl drip, they're never going to wake up because it takes forever. So in the ACG guidelines, we recommended the use of short-acting dexmedetomidine for sedation. In ventilated patients, we suggested against prophylactic antibiotics, and we're going to talk about that a little bit more about ventilation as well. Another thing that is so important is not all high creatinine is HRS AKI, as we know. And now this is 48 hours to 50% increase from baseline. But the latest analysis now shows, latest consensus document now makes it 24 hours, not 48 hours. That makes it a lot better. If a patient has cirrhosis in HRS stage 3 and 4 AKI, stage 3 is as low as 2 to 3 times the serum creatinine from baseline. So if the serum creatinine goes from 0.5 to 1.0 or 1.01, that is a stage 2 AKI, and that is very important for our patients who may be sarcopenic to start with. So if they have all of that and they do not improve their serum creatinine 24 hours, it used to be 48 hours, now it's 24 hours. And you want to make sure all of these things are also true. Only those people have HRS AKI. And we suggested norepinephrine or terlipressin to improve renal function in these patients, along with albumin and albumin as well. So albumin is very much important for AKI stage 2 and 3, but not for everything else. A thing that causes us a big problem is coagulation failure. Not necessarily patients, the people taken care of by the hepatologists, but this is actually more towards people who are being taken care of by either ICU people or when we need to do some interventions. So we suggested against INR to measure coagulation risk. INR is a very nice test for, as we know, for liver disease, but it's a very bad or incomplete test, I may add, for coagulation risk. We suggested against transfusion in the absence of bleeding or a planned procedure, and we recommend the use of TEG or TEG-ROTEM. For those who are not aware, this basically takes the entire blood, spins it, and sees how thick and how long-lasting and how strong the clot that ultimately forms is using certain standard parameters. This is used extensively in neurosurgery and other places where you want to absolutely make sure that the patient will not have a skull bleed. But this is getting harder and harder for us to actually put forth in our patient population. But this is something that is ideal. Infections are really a critical part, and I'm going to talk about that at length. Remember, our patient who came to the hospital with an undiagnosed SBP took forever to actually being diagnosed and even further to be adequately treated. The initial medication, ceftriaxone, did not help him. So this is a cleared consortium thing that we published in Lancet, and many people here in the audience, including Ramazan, who's the lead for us, helped and are part of this consortium, and I thank you for that. In 98 hospitals in 26 countries or regions, we had more than 4,000 patients, and 32% of them had an infection on admission. Remember, these are people who came to the hospital, did not need to have infections. 40% of them had a drug-resistant infection, which is really a bad thing. Infection characteristics, majority was SBP, like our patient had, followed by pneumonia and UTI. Most of them were culture negative. But the positive ones had gram-negative bacteria followed by gram-positive, and the gram-negative bacteria were E. coli, Klebsiella, and then after that was a gram-positive, which is Enterococcus. So again, most of these patients do not have cultures. It could be either because the culture is not available, or it could be certain things just skin and pneumonia, where we normally don't send cultures unless they're in the blood. There were huge amounts of regional variation. Low and low middle income countries, upper middle income countries, which include Turkey, and high income countries that includes the United States. You can see there's a big difference in the prevalence of infection. It was higher in the lowest and lower middle income countries, which included India. Culture positive rate was highest in the high income countries, most likely because this is really the way we manage patients a lot more here. So more cultures were sent. If there were more culture sent, there were more culture positivity rates. Drug resistance rates were highest in the upper middle income countries, which is including Turkey. The antibiotic treatment was written, you see this varied, and 22% of the patients with infection died compared to only 8% without infection. And this is a big problem. And the more likely you are in a high income country, the less likely you're going to die of an infection. So it tells you the infections are very local. So whatever you find in your infection is very, very different from some other group or other country might find. So what are the clues that indicate infections and cirrhosis? Because the usual signs may be absent. What we really need to worry about is altered mental status. What our patient has is exactly this. He had an altered mental status or hepatic encephalopathy, and that should have cued us that this patient had an infection to diagnose it quickly. Acute kidney injury. Now, we did not know what this patient's baseline creatinine was, but the kidney injury was present in this patient and certainly worsened within the next few hours. The asymptomatic patients can have a silent SBP. Now, this guy was not totally silent because he had encephalopathy. There's an increase in WBC count. Like I said with the creatinine, if your baseline creatinine is very low and it doubles, it may not cause you a big dramatic change. Same with the WBC count is low because of hypersplenism. If it's like, 3 to start with, 3,000, and now it becomes 6,000, it really will not cause a dramatic change. It will not alert you unless you are sure or know what that other thing was. What about inappropriate antibiotics? If you do not give the correct antibiotics, you have a 10-fold chance of the patient dying, which is exactly what happened to our patient. If you remember, our patient 6 weeks ago had an urgent umbilical hernia surgery. And that urgent umbilical hernia surgery then converted everything that he had subsequently from a community-acquired infection to a healthcare-associated infection. So our patient should have been treated right up front after the cultures were drawn for things that were actually much broader. And if the patient did not respond, you can actually go down to that. So what about albumin? Our patient got in albumin correctly because this patient had an SBP and had AKI. Should everyone get albumin? Non-SBP infections, it was not useful. And clearly, in this nice trial published in the New England Journal of Medicine, if more albumin was given just to maintain an albumin, this actually not only did not help, it made things worse by causing respiratory failure. So what do we want to figure out with infection? We want to check for infections. In suspected infection, we suggest early antibiotics. In patient not responding to antibiotic therapy, we recommend suspicion of a resistant organism like our patient had, or a fungal infection. In SBP, albumin with antibiotics is important, but not in other infections. We suggest avoiding PPI unless there is a clear indication. This goes for infection and precipitating factor. But you remember, it requires a team sport for this patient who's very, very sick. You want to make sure there's enteral nutrition is taken care of, volume expansion is taken care of, glycemic stability and electrolyte infusions are taken care of. We want to have hydrocortisone on the ready for adrenal insufficiency. You want to have a very experienced nursing, not just nursing staff, respiratory therapy, and its dedicated liver units actually do much better. Continuous hemofiltration if needed, respiratory therapy rather than hemodialysis, which could take a lot more patient effort and it requires a higher blood pressure. Hemodynamic monitoring is important. As I said before, we need short-acting sedations. Minimal sedation use is important. And again, intubation for airway protection if needed to prevent aspiration pneumonia. Our patient, remember, on 48 hours later, had a new right lower lobe infiltrate. That happened because this patient was not sent to the ICU and had an aspiration pneumonia, which was the pre-terminal event for this patient. You want to decompress tense ascites for these patients because it will be a problem otherwise. Patients will have issues with respiratory compromise. Microbial cultures, as you can see, there was huge gaps across the world for microbial culture selection. And more importantly, serial illness severity assessment. And this is where the ACLF guidelines have the biggest problem, because the person who is not ACLF today could get ACLF, could be ACLF tomorrow, and then day 3, the ACLF is gone now. So how are you going to give that person extra points for liver transplant when this is such a labile situation? So that's in countries like the United States, where majority of the donors are deceased donors. We have a national system. Should ACLF patients get extra listing priority for liver transplant? And this is the argument for. Patients are not very well served with MELD or even MELD 3.0. And in certain selected patients, there's acceptable survival post-liver transplant for these patients. There are futility rules that need to be satisfied, including one of these, which is present here, and another one, which is here. How do we actually make this happen? you can do two things. You can actually expedite deceased donor transplant. In this study from the United Kingdom that was just published, they actually found that if you were transplanting people pre-op, giving them extra points because they had ACLF, they obviously did very well. However, things in living donor are a little more murky. Living donor liver transplant in a couple of these studies was associated with only a 73% survival, and more high it required a lot of pre-liver transplant healthcare resource utilization. So it is very challenging for us to actually figure out whether someone should be given extra points, whether the system should be changed, or living donor should be reserved for certain specific people or not. What are then the arguments against prioritizing these people? Most of these studies were done based on retrospective analysis, and these data, including the UNOS registry, do not have the things that are needed for EASL-CLIF or NAXL in a complete way. And the other thing, when you're talking about deceased donor, there are only so many deceased donors. So we really do not have enough organs to go around. So if these people in that study were done by Dr. Bernal in the UK were given this, someone else then did not receive that organ. So you want to make sure that this is that the support is there before changing listing or priority criteria. So what do you do otherwise? In the patients who are not responding, you have to have a family meeting and consultation very early, because many of our patients, this may be their first or maybe their second admission for cirrhosis at all. And they slip very quickly, as you saw with our patient, from coming in with confusion to death in 2 to 3 days. So you want to start this before and not just when things are ending, because who knows when things are getting worse. So we want to have challenges. There are many challenges justifying priority. The concept of ACLF is very labile. Most patients with ACLF do not have liver organ failure, especially with EASL, unlike ARC. Challenges are implementing because scoring is complex, it's a heterogeneous condition, and alcohol-related hepatitis could receive further advantage, which is very much true in the United States right now. So what we said is patients with ACLF who continue to require mechanical ventilation due to respiratory failure or brain-related conditions despite optimal therapy, we suggest against LT listing. In patients with end-stage liver disease admitted to the hospital, we suggest early goals of care discussion and, if appropriate, referral to palliative care to improve resource hospital utilization. So back to the case. Many things happened to this patient, but we would have prevented it. We could have suspected cirrhosis early, but this was a problem because this patient did not have insurance, did not see anyone. We could have diagnosed the precipitating factor, which is the infection, SBP, in this person. We should have taken a close watch on the respiratory status and the creatinine because he developed, AKI. The early suspicion of infection, we waited too long to do a paracentesis. The early transfer to the ICU was not there because the patient then developed aspiration pneumonia. And of course, because this patient was not seeing anyone before, it was really a problem, and we really did not have time to involve the palliative care. So in take-home messages, ACLF is a high burden. We want to prevent it. Infections are very major, and we want to change the bacteriology, and mycology is changing. We want to have a high index of suspicion, flexible, rapid, and appropriate antibiotics, and prevention of AKI is needed. Not all high creatinine is HRS AKI, and not all confusion is hepatic encephalopathy. Use albumin selectively and avoid unnecessary PPI. Palliative care should be involved early, and transplant discussions should be approached with care. You don't want to promise transplant in people who are not going to be candidates afterwards. We need better biomarkers to predict ACLF, but metabolomics might be close. Thank you, Deshakur. And this is my acknowledgements. Thank you.
Thank you very much, Professor Bajaj. It was a gorgeous talk, really. Thank you. I have two questions.
Yes.
One question. Actually, we, as a ARC, we believe that golden window period is very important for the treatment. And in this period, sometimes we need some bridging therapy, like exchange, plasma exchange, and others. What do you think about the golden window? Because you never mentioned about the golden window. What do you think about that?
Yeah, I did not mention about that because I wanted to go one step further. Because golden window, etc., only come when the patient has developed ACLF or is on the path. I want us to go further. Why is this patient even in the hospital to start with? Because that's where we'll have the biggest return for our investment. if we actually treat the patients appropriately, the golden window to me actually is the window when the patient comes to the hospital for the first time. You want to prevent ACLF from even developing, because once it's developed, you're correct. We are basically at a loss. We are looking for things that either have little value right now, because there is a study that is going to be hopefully completed called Apache, in which they are formally studying albumin dialysis across the world versus no therapy to see if it actually works. Right now, the experience with Plex, like you're saying, is few and far between. Some centers do it, but they do it in people like lactate who are very sick. And they select out people for very much sick. So I would urge all of us to not wait till the patient is already in the hospital, but actually prevent this from happening. Because once this sets in, then we are talking about someone who dies in 10 days versus dying in 15 days if without a transplant. Now, you could say it's statistically significant, yes. But is it clinically helpful? Those 5 days, especially if the patients and their family are paying through their pocket for that 5 extra day of ICU, these are questions we all have to answer. So that's why I started with a case who had not already been in the hospital, because I think we are so focused on the end stage that we somehow take the focus off. This is the same patient who will have compensated cirrhosis with decompensated cirrhosis with ACLF. We somehow in our mind are like, this is decompensated cirrhosis, and that person will never become ACLF. It's the same people who go back and forth, back and forth, back and forth. So whatever we manage with decompensated cirrhosis, those are tomorrow's ACLFs. So if we prevent that, better things are going to happen for the patient.
Thank you. The second, actually, still we don't know exactly the usefulness of the liver support devices, and there are many studies. We use the Mars and Proteus, and also plasma exchange. And is there some also ongoing studies about this kind of treatment? And yes. I believe that, in my opinion, we have to use especially the plasma exchange for the bridging to liver transplantation. What do you think about this point?
We use it very sparingly. We don't use it, and I'm going to put it in the chat. This is the trial I was talking about, which is, sorry, there was like a lot of questions. So I'm now looking at the questions. Sorry, it was like, so yes, this is the Apache trial that is going on. So we don't usually use it unless patients are in this trial, but other colleagues across the world, including, have used it. But like I said before, they use it in selected patients, and you use it if they have a protocol. And the experience right now, we need a good randomized trial, and hopefully this will have hundreds of patients across the world. Will give us an answer, because we certainly don't want to give people false hope, right? If it is not going to work. And it's very hard to do for those who have done it. Plex requires an army of people. You saw that picture that I had of 10 people around one patient. It takes a lot of time. So I don't do it routinely, long story short.
Thank you.
Okay,
so yes,
thank you very much.
Ramazan, do you have any question, Ramazan?
His sound, he can open himself, because I already gave a moderator to him. Ramazan, you have to open your sound yourself.
No.
I already gave you a moderator. Okay, I already again I do it.
Okay, I'm going to answer while Ramazan figures it out. Maybe you can write it in the chat, Ramazan. I'll answer some of the questions.
He can write.
Avoiding
then
PPI
already we
use
had several questions by
yeah,
chat. So may I ask them?
Yeah, I can. Yeah, okay.
Yeah. MG, perhaps Murat Gülşen? You ask some question? Okay. So his question is, you said avoiding PPI use unless there's a clear indication. However, we know that ICU itself is a risk factor for all patients to GI bleeding because of stress. That's why PPI usually used in ICU as a prophylactic treatment. Why do you recommend? What do you recommend? Sorry.
So the stress ulcer thing I can get behind for certain cases. What happens when you start person on a PPI for this? It follows them for their entire life. And again, as I said, I'm not talking about the ICU. I'm talking about the patients with cirrhosis who can actually go into who are not really ICU material yet. Majority of the patients that you will see on PPIs don't need the PPIs right now, or were on PPIs for an indication that are not active right now. There is very good evidence that we need this acid barrier to prevent gram-positive organisms, especially from the mouth, to go in and cause things such as SBP in these patients. So if the patient needs it, absolutely continue it. Patients have severe gastroesophageal reflux disease. Patients have severe issues with, have Barrett's esophagus or have ulcers that keep on forming or have H. pylori. I mean, those are people you want to keep them on. But I can guarantee you at least 75% of your patients with cirrhosis, not the very critically ill ones, are on a PPI for an indication that has expired right now or an indication that was never good to start with. And you can always justify and change it to an indication to a H2 receptor blocker so that the patient feels better for occasional heartburn if they might have. A lot of these patients have severe ascites that causes a reflux in those patients. So if you fix the ascites, hopefully things will get better.
So another question is there any specific drug for ACLF treatment than acute decompensation treatment? After all, we have to treat according to the patient's condition. So why is there this confusion of definition between East and West? Do the differences in definitions lead to different approaches in treatment management?
Oh, there are 3 questions, Mao. Okay.
Yeah.
So I'm going to start with the middle one. Why is there confusion? The confusion came because the patients that we see are very different from each other. A lot of the patients seen in East Asia, not South Asia, are patients who might have hepatitis B reactivation or may have something else that don't have underlying cirrhosis but have some kind of chronic liver failure. In those patients, the liver is the center of everything. The liver failure and everything goes. So therefore, the Apazal-ARC definition is very liver heavy. The patients that we see in the Western countries are mostly patients who already have cirrhosis, mostly decompensation, and then they have extra hepatic impacts. So what happens is if you have an infection, the liver is a secondary player. Everything else becomes a problem. So the patients we see are the patients we serve. That's why these things are very different. And that's also in the bottom. The reason I started with the patient and not with the definition is because you can realize how this patient is not served by our current situation, even in a rich country like the United States, where you have all the things available. If you are not advocating for your patient, they will develop all kinds of organ failure, which will be ACLF in every definition possible. The reason why Dr. Sarin and I were very optimistic is we are having a meeting of the minds in San Diego, hopefully. We've made a lot of progress and come up with the point that clinical development as well as regulatory, etc., for organ failures are actually demonstrated. So we are coming together for this. Given a specific drug for ACLF treatment, right now there is no specific drug. There are drugs that are being recommended for being tested for specific diseases like alcohol-related hepatitis. There are studies on fecal microbiota transplant. There are studies on IL-22 agonists. There are studies that have failed, but majority of our patients do have alcohol-related hepatitis that can cause ACLF. But there is no generic study right now that is going on for ACLF short of this plex. But this plex happens for treatment for ACLF when it's developed. What we need is preventing. Again, I want to urge all of us to think about prevention at every level, because ACLF diagnosis either by ARC or by NACSELD or by EASL-CLIF does not do anything better for the patient. You are still going to treat the patient as a sick patient. You're not getting extra points for liver transplant. You're not giving them anything extra short of labeling them as ACLF. Right now, I want us to remember that the patient is still that individual person that we manage. And the ACLF, until it becomes a harmonious entity that everyone agrees on, that gives you either extra points for liver transplant or takes away points for something else, there is no benefit in actually diagnosing this unless we give them something better for this. So therefore, I hope the medications that we are in development right now actually can be harmonized throughout. Right now, there is nothing in the process. I'm sorry, this is a very depressing state of affairs, but we are getting better. We are getting better. So people from all over the world are meeting in San Diego, and hopefully we will have some answers to take back to our societies and think about how we can do. This Kyoto Consensus was a good step forward that we all, many of the people here are part of as well.
So Dr. Bajaj, Ramazan Idilman asks you, thanks a lot for your excellent talk. Can we give empiric antifungal therapy in case overseeing conditions and a non-response to first antibiotic in ACLF? Is a question.
Okay, I think this is important. Empiric antibiotic and antifungal therapy is absolutely necessary if you feel like your patient, especially in patients who have renal failure. But the issue is you have to have some kind of culture or somewhere to figure things out. So you can't just keep on starting without a way to pull it back. The biggest problem comes when we start on broad spectrum antibiotics without doing cultures first. So we are kind of stuck with that. And in our cleared consortium, that's what happened in some sites in Africa. Because they did not have ability to do cultures, they started their patients on the highest spectrum of antibiotics first. And at some point, their patients became resistant and they started dying. So the countries with the lowest ability to do the cultures are also the countries that potentially have the highest death rate, because those patients are the ones that are blindly treated for a very large thing. So clearly, if a patient is not getting better within 24 hours, think about a resistant organism or a fungus in those patients, especially with renal failure. And those are the patients which are really critical for us to actually have a way forward.
So the last 7 minutes, we will finish shortly. So is there any other question? Please, maybe we can talk to, thanks to him. Dr. Dökmeci.
There were some questions from Fulya and Irfan. Can you see, Necati?
I didn't see. Yeah, Irfan, thanks for this excellent meeting, both the organizers and speakers. He just thanks, that's all.
Okay.
And the MG, you said LDH is not reliable. Then how about LDH subtypes, especially LDH subtype 5?
I'm not sure about that, Dr. Gulshan. I think it's more of, I hope I'm pronouncing your name right, Gulshan. Okay. But it's lactate itself has been used, not the lactate dehydrogenase itself. Is that what you're talking about? It's just the arterial lactate.
Yeah, it should be lactate, right?
Yeah, they've not done into the subtypes because what we want to do is to make it as accessible to people as possible. Lactate is obviously much more easy for us to figure out. But my question again is, if we want to use lactate, we have to then put lactate in every patient that we see in the hospital, rather than the ones we see are in the ICU only.
Yeah, Professor Ahmet Gürakar, he is the very important hepatologist now working in the United States. Yes, Ahmet, would you like to add something to comment or to a question?
Yeah, just to comment, I think to comment on what Josh was saying, we don't know which patients we should not transplant. I think we try to transplant everybody, but I think he showed in the slides somebody intubated with ARDS on vasopressors. I think we used to transplant those patients maybe 10 years ago, but not now. I think even the surgical community knows that it's not doable, but I think we need to more. I think right now we are transplanting patients intubated on low dose of pressors, but are we going to be fading away from that approach also in the near future? That's why we need to hear from Josh and his colleagues telling us more about it. There's definitely a difference between East and West. and the East will do the living donors only, and which Josh showed that they don't do well. I think we're still learning, but we need to get more data. So thank you very much, Josh, for this excellent presentation.
Thank you.
So we have lost 2 minutes or maybe 3 minutes. So thank you very much, Dr. Bajaj, for your excellent lecture.
Thank you.
I think we have to thanks to
Okay.
all the audience. Okay.
Now, thank you very much. Now I close the session. I close this meeting. Thank you very much, Professor Sarin, also to Professor Bajaj, and also all the participants. Thank you very much. Have a
Thank
good
you.
time.
Thank you.
Bye-bye.
Thank you. Nice to
Have a
see
good
you all.
night.
See you all
Bye-bye.
in San Diego. Thank you.
Okay. Hope to see you there.
Ramazan